I'm going to do a bit of a continuation as to week 6. There's a lot of information. It was a heavy week. It was a very interesting week. In the previous video, or what I would call, let's say, part 1, this is going to be part 2. So I spoke a lot about the step care model, about risk, the different step levels, and the PWP role a little bit. You've got, when the IAP program was established, you have two. It was the whole idea of getting the funding and establishing this program is to make sure that you've got an evidence-based therapy or treatment using cognitive behavioral therapy, and sort of dividing it into 2 levels. You have the low intensity, mild to moderate, high intensity, moderate to severe, and these 2 have their separate trainings. So this is kind of like the level 1, and then this is like the level 2. So people who graduate in the low intensity CBT, the PWP course, what they will need after that is they need 2 years experience working as a qualified PWP in order for them to apply for the high intensity training. And the high intensity training, they deal with a lot of other things. They deal with like PTSD, which we don't deal with. They deal with, health anxiety. They deal with like first of all, disorders and conditions or problems that are high, high in terms of intensity. They're more complex, and also moderate to severe cases. So they kind of deal with that. Whereas here, mild to moderate, as I mentioned previously. You might hear me saying these again. It's just to remind you so that, you guys know that there is a difference. So there's low intensity and high intensity. So a continuation of this one is just to let you know that we were also learning about when we have our service users, people who use the service, how can we get engaged with them even after their recovery, as to how did they benefit? What was the treatment like to them, the whole session, the service, what was it like to them, their experience within the service, their experience in their recovery, for them to also recommend the service, recommend talking therapies, or LICBT, or high low intensity or high intensity, but to recommend them the IAPT service in general, improved access to psychological therapies. Now they're starting to change and calling them more talking therapies, which I think is good. It's a good step that we change the name, because IAPT seems it seems like too much of an acronym. But even within talking therapies, personally, I feel like talking therapies is still ambiguous, because what is talking therapies? Talking therapies is so many different therapies. You've got CBT, which is cognitive behavioral therapy. You've got dialectical behavior therapy. You've got acceptance and commitment therapy. You've got motivational interviewing. You've got solution focused therapy. You've got interpersonal therapy. There's so many different other therapies. So when you say talking therapies, there's a lot. I think we need to kind of like slowly become more specific, because talking therapies is quite ambiguous. But when we say talking therapies in the service, the IAPT, the core of IAPT in a way, which is low intensity and high intensity, these things are provided and these services are delivered. And depending on the service, other sort of talking therapies are now starting to be introduced. You have people who deal with psychodynamic, you have people, or psychoanalysis, you have people who deal with dialectical behavior therapy for people who have personality disorders, particularly borderline personality disorder, and you have others coming up, which is good and really helpful. It helps in order for us to provide the best, and in order for us to provide what we can for the community and the borough and the service people around us. All right. So we're learning about why is it important that we engage with clients and service users in order to get their feedback. Feedback is important. Knowing what did they benefit, maybe some of the pros and cons, so that we know where we can improve, where are the areas for improvement. So finishing from our ASCIIs, now we are prepared for actually delivering assessments. Although we were advised that we'd wait till the end of April, because by the end of April, fortunately, we finished our second module, and now the whole purpose was that by the second module, we're ready now to see clients for treatment. And with that, we know the assessment. We can now deliver assessments. We can now start delivering treatment, and that is something that is very, very important. I'm going to mention more, don't worry, in regarding to this week, and also in regards to this week, some interesting news. But anyway, let's focus on week 6. So that was, the whole idea that week was learning about setting up treatment, starting to shadow other qualified PWPs. We all have a buddy or a mentor assigned to us, so we get to utilize that and leverage the fact that we can shadow as much as possible with them and with others. And many of the qualified PWPs, they're great people. A lot of our staff, they've been very helpful and very welcoming. That's the most important thing, and that has been a great experience for myself and all the other trainees. Not only my service, but all the other services. We feel very fortunate that we have wonderful people that we work with, very welcoming, and everyone understands the struggle that we all go through because they've been there as well. So we're all here to help, and that really helps. Client engagement, something else we learned, and also a little bit about diversity. We were looking into this issue very, very, very not in too detail, but we got the introduction towards diversity, which is actually in the 3rd module, and understanding diversity. That we are going to be dealing with people from a diverse backgrounds. London is a diverse city, and so many different boroughs. I was reading in some of the articles and some of the web pages, and honestly, some boroughs in London, like the whole of London, but certain boroughs of London, like the whole of London, you've got more than 100 languages spoken in this city. Lewisham on its own has so many different languages and so many different cultures. It's so multicultural. Everywhere you're seeing different people. So it's about understanding culture, understanding religion, understanding people's beliefs, people's values, people's principles, where people are coming from, their understanding of life, their understanding of what they are experiencing. Because, for example, in many cultures and beliefs, and many cultures and many even religions, there is the belief of the understanding and a perspective as to what are the causes towards mental health, mental health problems. For example, a lot of them, tend to have the belief of spiritual possession, for instance. Yeah, and it's good and it's important that we understand that this is their perspective. This is how it is viewed. For example, in Islam, we do have something called spiritual possession, for instance. We do, and that is actually there. There's spiritual possession, there is envy, there is the black eye, there's magic, that things that we believe in. And there are times where this is the case, there are times where it might not be the case. We have to look at both sides. So what I'm saying is that it's understanding, how the person perceives it. And this has been an issue that has been spoken for a good, probably throughout the last decade. I even remember one of my lecturers back in uni, not UCL, when I was studying my undergrad it was a module of counseling psychology. And she is actually from the US. She's actually like half African American, half Latino. I think she was a mixture of both. Yeah, half Latino American and half African American. An amazing lecturer. But she really went into a lot of depth with multicultural counseling and about people's certain beliefs and cultural beliefs towards certain problems. It was amazing the way she explained it. And really, we are seeing that because within, different parts of the world, you find that you've got the locals and you've got people who are from different parts of the globe, different parts with certain, like I said, beliefs, culture, religion, values, principles, perspectives as to how they see and how they experience and what they believe to be is causing, or the main factor that's causing their mental health problems. So that was honestly an amazing week. It was exhausting, it was heavy, but a lot of learning. And you've also got, when it comes to diversity, not just the cultures, generations. Remember, there's a generational understanding. What people 20 years ago, 30 years ago, 40 years ago, and 50 years ago, and 60 and 70 years ago, their understanding of mental health may be different. Their experience of mental health may be different to what we're experiencing now. We've got loads of stuff coming out. We've got a lot of changes. Back then, there was no social media. Nowadays, social media, mental health, this is a huge topic. Back then, it wasn't. So generational differences, understanding who we are talking to, as well as people who have, let's say, learning difficulties and so on and so forth.